A couple of recent posts have popped up on the LinkedIn feed that have started a bit of a firestorm within the PT profession and between the PT profession and a couple other professions like nutrition and dietary. And I'm going to talk about what those things are. The topic at hand is if PT should be involved in giving out nutrition and dietary advice and how we should be talking to patients about it, what our role as PTs is in the overall health and wellness of our patient, how these lines get blurred and crossed. We're going to talk about that in the podcast today. I'm going to talk about if I think it's a good idea for us to get involved, how much involvement we should be having, and where we should be going. I'm going to hit the intro and I'll talk to you in a little bit. Defending mediocrity in our profession. Welcome back and thank you for joining me on the Dr. Krol PT and Fitness Podcast. I am your host, Dr. Lee Krol, physical therapist, and what we're talking about today is if PT should get involved and how much we should be getting involved in giving out dietary and nutrition advice. So a few posts have popped up on my LinkedIn feed, a couple of articles have been written on a couple of websites about PTs getting involved and how it's well within our Practice Act to do so. We should be getting involved. We have some nutritional training in our educational programs, especially the undergraduate side of things. So we should be getting involved in helping people out with dietary and nutrition advice. And first and foremost, I want to say that a person's diet, their nutrition, the way they eat, their food habits are absolutely important and connected to their not only their overall health, but to the way they move, how their nervous system reacts, and how they perceive pain. So if a person has poor sleeping habits, if they have poor hydration, if they have poor nutrition, then the likelihood that they're going to come out of a chronic condition well is very low. The likelihood they're going to come out of chronic pain is pretty low. The likelihood that they're going to perceive things as more of a threat, or their body is going to perceive things as more of a threat if they have poor hydration, poor nutrition, poor sleep patterns, is much better. And their peak performance is going to go down. Their mobility is going to go down. Their strength is going to go down. All of these things are stacked on top of a good nutrition and a good hydration profile. Our patients and clients, I don't think there's any problem with us talking to them about this. I don't think there's any issue with saying, how are you sleeping? How are you, are you drinking enough water? How's your diet? Is it poor? Are you eating a lot of processed foods? Are you eating a lot of fruits and vegetables? What type of things are you eating? I don't think that's outside of our realm at all. I don't think that's even inappropriate for us to ask. No more than I feel it's inappropriate for us to ask red flag type questions. Really what this is doing when we ask red flag questions, or we ask questions that are maybe outside of what you would consider our direct practice area, is that we're looking for things that may be outside of our practice area that we have to refer out to. So that's kind of where I feel we should be kind of going with this. But there is this idea in the PT world that we should be giving out a lot more dietary advice, and we should be spending more time talking about nutrition and diet and helping people make these things better, because if they don't, then our ability to stack exercise and mobility and everything else on top of it is going to go down. People are going to feel better. They're going to move better. They're going to perform better, whether it's strength, power, mobility, skill, doesn't matter. They're going to perform better if their hydration and nutrition profile has improved. I don't think anyone would really argue that. But the question I have is, who takes care of it? Who is best equipped to take care of it? Now, we can do continuing education courses. We can read up on nutrition and diet. And that's not a problem for us to do. We have the educational background to understand the knowledge. Again, that's not a problem for us. But what I would say is, how much training should we have on top of our doctorate education? And I'm not talking formal training at school. How much postdoctoral education should we get before people would really feel comfortable saying, hey, you're a specialist enough to be taking care of that? And, I would look at it from the dietitians and nutritionists standpoint. That is what their training completely entails. They go into nutrition and dietary, and they are working specifically to handle people's nutrition profiles and their dietary profiles based on a lot of factors that we just don't know as PTs. We can take some education on it, but we don't really know it as well as they do. So would they be uncomfortable with PTs going into a patient encounter and starting to take over that realm and spending a lot of time on it and prescribing things like dietary plans, nutrition plans, eating plans that maybe the nutritionist wouldn't agree with? And I think they would, and I think they would have a grounds to be upset about that. I look at my practice in particular, and there's two things that really, really irritate me with physicians. Number one is when a physician sends someone to me, or I get a referral from a physician and they have exactly what exercises they want done. That pisses me off to no end. That really drives me nuts. I think that is completely inappropriate for a physician. It doesn't matter if they're a physician, a physiatrist, an orthopedic surgeon, whatever, to tell the PT exactly what they want done. What's the point of sending them to the PT then? Just have them do it in your office, shoot a bunch of videos, put it on your website, and have your patients do it. There's no reason to go to the PT if you're telling them exactly what exercises to do, which leads me into the second thing that pisses me off, is when they give the patients exercises, then they don't go to PT. They say, oh, just do these exercises and you should be okay in 3 to 4 weeks. And then the patient doesn't get better. They come to see me via direct access. I look at the exercises and I say, wow, these are complete garbage. These are not appropriate for this person. They didn't solve the problem. They didn't even address the real problem. When I see people that have a chief complaint of knee pain, they go to an orthopedic, they go to a physician, they go to whoever, and the physician just gives them a cookie cutter exercise sheet that basically just exercises and tries to strengthen all the muscles that cross the knee. Complete garbage, usually does not handle the problem at all, and honestly, it usually makes it worse, in my opinion. So, I don't like when a physician, a physiatrist, a podiatrist, a orthopedic, in my opinion, oversteps and steps out of their lane and goes into the rehab lane, because simply put, they know very little about rehab compared to the neuromusculoskeletal physical therapist. The neuromusculoskeletal physical therapist, who deals in these outpatient type encounters all the time, knows way more in terms of rehab and exercise prescription and movement diagnosis than the physicians ever will. That's not the physician's role. The physician's role is to make sure that the underlying pathoanatomy is as good as it's going to get, or is taken care of with either more invasive means or pharmacological means, whatever outside of what the PTs can do. The PT's job is to make sure that the person is moving as well as they can, and all the factors that can influence that area kinetically are taken care of. So if it's a knee issue, are we looking at the ankle? Are we looking at the hip? Are we looking at repeated movements of the spine? Are we looking at the thoracic spine, breathing patterns? All these things really matter in terms of the knee's kinetic profile. And if you just strengthen stuff around the knee, it doesn't work. So the physician giving out exercises and not sending them to PT is a real problem. It prolongs care, it makes the person's condition more chronic, and it usually makes them worse. On the same token, would the nutritionists and dietitians feel the same way if a PT with maybe a couple MedBridge courses and maybe a book or two that they've read postdoctoral takes it upon themselves to give out a nutrition profile, to give out a dietary plan to these individuals that isn't not appropriate or is not effective, and then the nutritionist looks at it and says, well, they should have sent you to me and I would have taken care of this with my expertise. Maybe the PT should have stayed in their lane. And I would have to say I kind of agree with that. I think that we should really kind of focus on staying in our lane, but have enough nutritional background, have enough dietary background to figure out, okay, nutrition profile is a real problem for this patient. Let me get them to the right person. I think that's completely appropriate. And I think having a little more knowledge in nutrition and diet would be a good thing for PTs. But when we jump over that and say we should really be giving out dietary plans and dietary advice, I would feel a little bit uncomfortable with that myself. And I think nutritionists and dietitians would feel a little bit insulted by that, just like I feel insulted when the physicians start giving out exercises or telling me what to do. I would never send a patient to a physician and say, here, give them gabapentin. I would never tell them to do that. Just like I would never tell a nutritionist, say, here, I'm sending this patient to you, give them this nutritional profile or this dietary plan. That's completely inappropriate. So I think having an understanding of nutrition, diet, hydration, all that stuff, and its effect on health, its effect on movement and performance is a very good thing. But stepping over that line and trying to treat it, I may be a little bit uncomfortable with that. There's even things within my profession that are completely within PT's practice act, or completely within PT's scope, and they're completely within PT's treatment realm that I don't do. I'm not a vestibular specialist. I'm not a pelvic floor specialist, but I know enough about them to pick out, hey, this is a vestibular problem. And if it's a posterior canal, BPPV, yeah, I can take care of that for you. I can work on it, but I'm still going to refer you to a vestibular specialist. I'll get you out of the woods right now, but I want you to go see a vestibular specialist, not only to finish the treatment, but to maybe give you things that are appropriate to make sure that this doesn't happen again or reduce the risk of it happening again. I know a couple of vestibular specialists in the area that I refer out to, and these people have far more training in it than I do. I have some postdoctoral training, but not to the level that these people do. These people have a lot of postdoctoral training. They have a lot of equipment that I don't have. They know how to use the equipment where I don't. They have a better differential diagnosis with vestibular system than I do. So let them treat them. I know they treat patients well. I know they see one patient at a time, all that good stuff that I always ramble on and on about. So I'm good enough to pick out this is probably a vestibular issue, but I'm also within my realm, and I say, let's go see the vestibular specialist. Just like pelvic floor. I can pick out this might be a pelvic floor problem, or there may be a pelvic floor involvement. I'm going to send you to a pelvic floor specialist. I'm going to send you to someone who really knows this area, can really do not only the external work, but the internal work that's involved with pelvic floor physical therapy. And I think that's really a good thing. I think that's, there's a room for a jack of all trades, but there's also an understanding of we need to kind of stay in our lane. We need to say, okay, we have an understanding of nutrition, but maybe we shouldn't be doing dietary profiles of people. Maybe we shouldn't be doing nutritional profiles of people. That being said, what if you're a PT who has extensive training in this realm, has extensive training in nutrition and dietary? You've taken a ton of extra courses. You've taken a ton of extra certifications. That's a different story. That's fine, but that's an individual who has a lot of specific individualized training. I think one of the problems with saying PT should be more involved in this is that we're taking the bottom 60% of physical therapists out there and saying, you should be getting involved in this. When that bottom 60%, let's be honest, all they want to do is go to work, get a paycheck, go home, hang out with their wife, their husband, and their kids, and not think at all about anything else relating to PT. They do the easiest MedBridge Con Ed they can find. They do the easiest Con Eds they can find in terms of video or things that are very convenient for them, either done through work or whatever. They're not really interested in doing high-level extra training that would be required to give out a nutritional profile or even speak intelligently about it. So we probably shouldn't be talking to that bottom 60% of PTs out there that won't put in the extra work, that are just getting by and doing good enough to not get fired. That's kind of where I run into a problem, and that's kind of where I think the nutritionists and dietitians run into a problem, is that's what they hear. They hear that, PT should be getting involved, and they think about the, C's get degrees type physical therapist out there who just goes through the motions, sees 4 patients an hour, cookie cutter exercise program, and says that PT is going to start giving out dietary advice when they have no business doing so. And I would completely agree. The top 5% of PTs, sure, they're going to put in the work. They're going to do the extra Con Ed required to speak intelligently about this. They're going to keep up on the research if they start adding dietary things into their treatment plans. But for me, I think we should be having enough knowledge to find out this is a dietary problem, this is a nutrition problem, and get them to the right person so that they can handle the nutritional needs while we take care of the neuromusculoskeletal needs conservatively. that's my take on that. Not going to be overly popular with some of the more progressive thinking physical therapists out there that want to push our field into a broader realm and sort of the overseers of all things health. I don't know if that's really appropriate. I think it's appropriate if you have a lot of extra education, but that doesn't apply to our entire profession. I think our entire profession would have to come along with that, which means more education at the collegiate level. That's going to be a hard sell to say, let's give another year or two of education where we have to pay for it when our salaries won't increase. That's going to be a hard sell. So this is Dr. Lee Krol signing off about all this. If you liked what you heard, hit that like, hit that subscribe, hit that share, hit that little bell on YouTube. It'll let you know when more videos are popping up. Feel free to share this on social media. If you disagree with what I'm saying, that's cool too. Leave some comments. Let's find some talking points. Give me some extra material to go through on another podcast. We'll figure this out. We'll talk about these things. I like talking about things that are a little uncomfortable, that make people think, that make people maybe even a little bit irritated within the profession. I think that's the only way our profession grows, is if we have a couple of uncomfortable conversations. This happens to be one of them lately. I wanted to chime in and give my thoughts. This is Dr. Lee Krol, PT, signing off, and I will see you next time.